And so for me, there is a fulfillment in being able to demystify it, give them the diagnosis, and then, you know what, to walk away, right? Because now I've done my job. Like, for example, if I have like an 8-year-old girl who is giving a blood smear, to me, that's my daughter, right? I almost always ask myself, if this was my mom, what would I do? Or if this was my own specimen, what would I do? And whatever the answer is what I do, right? I mean, it becomes pretty clear.
Hi, everyone. It's Stephanie with The Patient Story, and I hope you're doing so well wherever you're joining us from. I'm really excited about today's conversation, especially because it's unique. It's something that we haven't done before, and will, I think, shed some light for a lot of you out there on why we're waiting for results sometimes, and for what's happening, what's going on. So without further ado, I'd love to welcome our special guest, Dr. Kamran Mirza. Welcome.
Absolutely. Well, it's a pleasure to be joining you all today. So my name is Kamran Mirza. As Stephanie just said, I am a pathologist. I'm a husband, a girl dad of 3. I originally am from Pakistan. I grew up in England and then completed medical school in Pakistan before moving to the United States. I've been in Chicago pretty much most of my adult life. I love art and art history. In my work life, I'm a hematopathologist, and we'll talk about that. And so when I was finishing up high school, or the high school equivalent in Pakistan, I decided to apply to 2 schools. One was an art school for architecture, and one was a medical school. My parents are both doctors, and, classic South Asian. I was like, oh, I don't want to become a doctor. All my life, I was like, I'm not going to become a doctor because, it'll seem too much like I'm following in my parents' footsteps. I was like, you know what? I was 18 and I was going to let fate decide. There's no way I'm going to get into both schools, but I did. And then so that didn't help. And then I made a conscious, informed decision to go into medical school, and I don't regret it. I think that there is I would say, an artsy side to me. And so actually it ties back into pathology. It's a very visual field of medicine. And I almost always think about, the fact that in pathology, I kind of blended my love for art and for science together. A pathologist is a physician that deals with the diagnosis of disease. So all of you listening, if you have ever been to a doctor, you had another doctor in that team, you just never saw them, and that doctor is a pathologist. We work behind the scenes mostly. We have little, if any, direct patient interaction, although there are some pathologists that do see patients. We work in the laboratories and in departments, usually in the basement. So my office is on the 2nd floor. I have a nice window, so that's really nice. And we deal with the diagnosis of human disease, looking at tissues or specimens from humans. And so our work is at the cellular level, right? So we look at the specifics of what your cells are telling us, right? Are the cells telling us that the cells are normal, or are they telling us that there's something happening to them, right? And so we interpret that. It's actually very intimate if you think about it, right? Because if a person has a mass or a lesion that's biopsied, it's a very vulnerable position that there's a physician who's actually looking at the cells. And I think that while the patients aren't aware of that interaction, obviously the physician pathologist on the other side is. And to tie it back to your question, the human body is beautiful in its symmetry sometimes, in its the way the cells are, the types of features the cells have. Some cells have extensions, some cells have big nuclei, some cells have small nuclei. And so while scientifically I never describe what I see as beautiful, because that would probably be disrespectful in case it's like a horrible cancer, but from an artistic perspective, looking at what the human body looks like on a cellular level or a genetic level is beautiful. Really, it's just a wonderful, tapestry really of different types of cells. And so I think that on a day-to-day basis, I'm looking at blood cells on a smear. I'm looking at bone marrow cells. I'm a hematopathologist. So that's the diagnosis of leukemia and lymphoma. And I think that there's a visual beauty to diagnosis, which, is part of every patient's disease journey.
Thank you for sharing that part of it. And, before we move into exactly what you do day to day, kind of filling the blanks, because I remember being a patient and going through tests and waiting and wondering what's going on the other side of things.
Right.
What drew you, though, in terms of, so I know you said you were into medicine. You said you liked it. You just had an affinity for it. But why in particular pathology? What drew you to that? We don't hear as much about it, right?
So what drew me to pathology, it was kind of an interesting decision. It wasn't clear cut. Pathology isn't really well exposed as a career to medical students. They study the pathology of disease as part of their preclinical curriculum, but they don't really see what a pathologist does in practice. And so it's not like, it's not front and center as the choice, within the choices of what type of doctor you're going to become. For me, I loved interacting with patients. I thrived on it. And so it was, my friends were, they were confused. Like, why are you choosing a life where you're not going to see patients as often directly? And I think my answer to that question is, after having seen pathology, is that every day is so different. I see so many patients on my microscope, right? Multiple biopsies, multiple specimens, laboratory tests, etc. So I can affect a lot of patients, hopefully with the right diagnosis, right? So that's one. The other is that there is beauty in being able to demystify human disease. It's really the last, it's the gold standard, right? Everyone else in the diagnostic process is kind of guessing, right? Like patients present with a particular type of set of symptoms and signs, and more often than not, there's a nice differential diagnosis. But the pathologist is the one who looks at the tissue and can give you the definitive diagnosis. So I think that really intrigued me, really being able to demystify the disease and, intellectually think about what's happening on a cellular level that is making patients sick, and then, correlating it with how the patients presented. So, we are clinicians. We are thinking with the clinical part of medicine, clinical part of our brains, but we're looking at, tissues and interpreting what the tissues are telling us. And so I think that really drew me into it. And so now I am a specialist, who's part of a patient's healthcare team, but my specialty is the diagnosis of the disease. And I think that that's an incredibly important step, because I think it's the first step in the journey of healing.
Wonderful. So, let's go there now. Let's talk about it almost in this, path of from a patient experience perspective. So I remember, I can't even remember, like going into UCSF for that first week, they wanted to run tests because they knew it was lymphoma, but they needed to figure out like T cell, B cell, which kind of lymphoma, all these things. So I had, lymph node biopsies, bone marrow biopsy, million scans. But in terms of the biopsies and even the blood work, like what is being done by the pathologist, and if you walk us through how long it takes, so it helps inform us like what's going on.
Often patients think that their tissue has gone into this black box. And actually, many of my physician colleagues don't really know what's happening in the pathology lab too. It's kind of a mystery for some reason. But, rest assured that once your sample goes away from your site, it's being taken care of, to the highest degree of care. And whether it be blood or whether it be, bone marrow or a different type of biopsy, there's certain similarities in the ways we process those specimens to be able to interpret them. Some will be faster, some will be slower, and it really does depend on what type of information we're looking for. So, for example, in a blood specimen, if we can just use that as an example, it's a relatively, it's a relatively simple biopsy if you think about it, right? It's just a needle prick and you get the blood, and then we can do several things to it. We can smear it on a slide and look at the cells. We can count the cells. We can see if the cells are looking normal or abnormal. And then our machines in our laboratories, in our clinical laboratories, they're medical laboratory scientists that are working with these samples to make sure that the numbers are okay and everything looks normal. In case machines or human beings, whoever's looking at those cells, see something abnormal, then those are flagged for review by a physician, which is a pathologist, right? And so as a hematopathologist, I get to see in the morning all the flagged smears that have probably something abnormal. And then I have to triage and see, is this abnormal in that it's malignant? Is it abnormal in that it's reactive? Like, who is the person? I always give this example that if a 6-year-old has a fever and a high white count, who is the person who will tell their physician whether this is an infection or leukemia? And the answer is coming from the laboratory, right? Because the presentation will be very similar. The patient might have a fever, might feel poorly, right? And the white count will be increased, but then we have to look at the cells and say, are they malignant cells or are they reactive cells, right? And so it's an incredibly important and really like a major responsibility to get that call correct. So, for example, if a patient has an infection, there's an increase in cells that is it's a reaction to the infection, right? So, for example, if it's a bacterial infection in the blood, there'll be lots of neutrophils, which is a particular type of cell. So, if I see tons of neutrophils as the reason for the increase in the white cell count, my guess will be, okay, this is likely a reaction to the patient's infection. So, my recommendation would be check out, the microbiology studies or see if the patient has an infection. This makes sense. But then there could be lymphocytes, which is a completely different kind of thinking about what type of infection it could be. There could be monocytes, and then there could be immature cells. And when we go into immature cells in the degree of their maturation, that's where we can start wondering about or worrying about, okay, this may not be a reaction. This could be a malignancy that's causing the increase in the cells. So things like that can be quick. So the turnaround for that, depending on how long it takes for the specimen to get to the laboratory, we can report certain things within an hour, right? So those are fast things. But then when you take tissue, if we move to biopsies, when we take tissue from the human body, whether this be in surgery or whether this be a biopsy, what have you, that material needs to be processed in order for it to then come as a slide to the microscope, right? And that usually involves some element of fixation. So fresh tissue, as you know, will start degrading very quickly. So we have to immediately take the tissue and put it in a fixative so that the cellular form and the cellular biology is kind of frozen for us to be able to process it. So normally that's formalin fixation, even though there are multiple other types of fixatives. But we process this tissue, we fix it in formalin, and then we embed it in like this wax, which is paraffin, and then we cut thin sections of it. And those sections come on our slides. So that process can take a few hours, right? The fixation takes a few hours. Depending on what time it is, it could be overnight, right? I mean, so we're now looking at going into the next day. After the tissue is on the slide, it's kind of see-through. It's just transparent. So we have to put a stain on it or lots of stains on it to see what the tissue is looking like, right? So that takes a couple more hours. And then based on what we see, it could be an instantaneous answer that everything looks normal. It's just normal tissue. Or it could require additional studies. So for example, if I take the example of lymphoma, it's not enough to just say, it's lymphoma. As you mentioned yourself, we have to figure out if it's B cell or T cell. And then within that, or is it Hodgkin lymphoma? And then within that, are there certain markers that we know will give a better prognosis or a worse prognosis? This could involve looking at a patient's in the tumor, looking at the genes, looking at mutations, looking at chromosomes. And so this can now take from a couple of days to like weeks. And that naturally can be very frustrating for the patient who's waiting for that answer. But I want all of the people listening to know that they can be rest assured that we are very acutely aware of the fact that delays cause more stress. But that if there is a delay, or if not a delay, but if it's taking a long time, we are in the process of getting the correct answers so that your, in my case, the hemonc, for example, can consider the state of diagnosis and prognosis so they can think about therapy appropriately. So, it's nice to be able to get a preliminary, answer. And we often do that. Like I'll pick up the phone and call the hemonc and say, okay, it's looking malignant, so this will take some time, right? And then it's up to them to triage depending on how the patient is. Are they kind of calm or are they very stressed out? And that's the side we don't deal with because we don't see patients directly. But more often than not, for example, if I'm on service today, if there were any surprise diagnoses, malignant diagnoses, I have called my clinician, like patient-facing colleagues, and given them a heads up that this is happening, so they can temper kind of the expectation of how long it'll take.
One quick question too is just some hospitals and medical centers have pathology labs on site, and many in the community do not, right? Or they'd have to send it somewhere else. Can you describe that a little bit? Because that factors into wait time as well.
Absolutely. So the larger academic centers, like you mentioned, UCSF, you're absolutely right. All of them will have a pretty robust laboratory on site where not only will the tissue processing happen on site, but most likely all of the molecular genetic studies, everything can be done like right there. There are some hospitals that are academic and they can do much of like 90% of it on site, but then maybe 10% is sent to a bigger laboratory, right? Like there are these large conglomerate laboratories that do testing for like other labs as well. And then, like you mentioned, if it's a smaller community hospital, which are great hospitals, but they may not be able to sustain large pathology departments. And so they will usually break up the situation such that they'll be able to offer the immediate testing on site. So for example, some immediate types of tests you can get results for immediate, like right there. Like those are the decisions that need to be yes, no, immediately enacted. And then if it's, tissue processing, etc., then, sometimes they do have like off-site partners, or maybe they have a laboratory that caters to 3 or 4 different hospitals. So that model also exists. And I guess, I mean, for the patient, you don't have to worry about exactly what model it is, because I feel like, I hope that it'll be excellent pathology care, but it does factor into delays. So for example, if a tissue comes out and has to be fixed, but it has to go off-site, then there'll be a transportation delay, etc. However, once it's reported, with the electronic records, like the report comes out immediately. And, with the Cures Act, actually patients sometimes see the report now, even without their physician seeing it. So yeah, the reporting is instantaneous, but the amount of time that it takes from the biopsy to us being able to give an answer is variable. And I think I'm also aware, because I've obviously been a patient too. In my mind, the second the tissue comes out of the human body is when the clock starts. But the reality is a pathologist may not actually even, get the tissue for like, let's say like 12 hours or something, right? So our clock in the laboratory is kind of different. And so I think that there are lots of these necessary but kind of unfortunate delays that have to happen for things to happen appropriately, which cause delays and understandably frustration. But hopefully the important thing is that if you get the right answer, you don't want to force it to be too quick and get the wrong answer, right? Because that's not right. And so getting the right answer is, like I mentioned, the first step in healing.
I completely agree. You brought up a really interesting point that I did want to talk about, which is this whole thing with Cures Act and the instantaneous results. And look, everyone can, have it be a notification. Like I'm notified as soon as I get something. I remember for me, I would get emails. I don't know if I got texts, but I got emails anytime a new test result came back. And, or I'd be on the app refreshing it constantly.
Right.
What are your, we talked about this a little bit, but what are your thoughts, first of all, on that, just as a setup? Because this is, look, it's your words. You're the author writing these words on this report that will, meet the eyes of these people who are usually in a very overwhelmed state of mind and state of being. So what are your thoughts?
I'll start by saying that the pathology information or the diagnostic information of a patient is the patient's property, right? If I'm writing a diagnosis for the patient, they have full right to know that immediately, right? There doesn't need to be any filter through which they get that information. But there are many caveats to this. One is who is the patient we're talking about? What is the patient's baseline understanding of the disease that they're talking about? I mean, maybe they don't have any idea about big jargon, right? Molecular jargon, etc. To be honest with you, I write my reports for the patient-facing physicians. The consultation that I'm getting is really, so I'll just use my example. A patient presents with suspected leukemia or lymphoma. They go to a hematologist, and that individual orders a test for a biopsy that comes to me as a consultant. So when I'm consulting on that tissue, I have two stakeholders. Obviously, the patient is my number one stakeholder, but number two is the physician who sent me that consultation. And so my report is classifying what the disease is, and it is written in jargon that is in response to the consultation that I got from another physician. Now, a lot of stuff can get lost in translation in this interaction, because really it is a conversation between two physicians, but it is about a patient's material. And now the patient will get that result immediately. They might get it when their hematologist is in a busy clinic with other patients. And this hematologist doesn't have any time to have even looked at that notification, but that notification went out to them and also to the patient, and the patient opened it immediately and now is reading words like acute leukemia, cytogenetics, looking mitosis, malignancy, neoplasia. And there's no filter. The physician that could have filtered that information, that could have sat this patient down and said, all right, we're going to have a conversation. Take a sip of water. We have the results back. This is what this is. This is what this means. And so I think that there's a positive and a negative, really, like in any situation. I think there are pros and cons.
I do appreciate how you presented this. I also appreciate, I had asked, well, what about, I can tell you do like talking with people. I think you're really great at explaining things. So you certainly could write a report that would be more,
right.
Layman friendly, more patient caregiver friendly, but there are limitations, right?
Right. Because I think that, again, it's like writing an email or a text, and you don't know how the person reading it is going to interpret it, right? I mean, do I put a period? Do I put an exclamation mark? Like, I mean, the tone of how I'm speaking is different when I'm speaking in person, and it may be quite stressful to read it. You've been a patient, you've gone through a whole diagnosis, right? I mean, and I think that you would have been even more empowered if you saw your cells, etc. If you chose to. I mean, it's possible that some people don't want to see it, and that's fine. But if a patient feels that they will be more empowered by seeing what it is, I think that one of the pathologists who is seeing patients, I think they titled a very interesting paper, and I think it's called, and I hope I'm not misspeaking, it's called "Help Me See the Dragon I'm Slaying," right? So basically for them, they were helping their patients see the dragon that they're going to slay, or something to that effect, of that this is the obstacle and now you're going to try and overcome it, right? And I think that for some people they want to see the dragon, for some people they don't want to see the dragon. But understanding more about their disease process, if a patient is interested, I think can only help them. But the jargon I have to use has to be scientific. I can't, because there's a criteria for words being used that will be looked at by insurance companies, by people auditing diagnosis, that God forbid, if I make a mistake or something, that if I ever get sued, people will come back and say, okay, what did he say, right? And their classification system, so I have to use those words. So a part of the report I can't change, even if I wanted to make it more friendly for my patient. So that portion will stay the same, right? I can't if the diagnosis is acute myeloid leukemia, those are the words I have to use, right? Because my colleagues who've given me this consultation know what to do with that information. I can't call it malignancy of neoplastic white blood cells. I mean, my job is done. I've done what I needed to do. So in that sense, I have to be respectful of my colleagues, but ultimately the priority number one is my patient. And I think it's important because patients getting that information directly also allows them to consider things like second opinions if they want to share information with other people if they want to. Could that help the whole process of disease diagnosis and perhaps correct diagnosis? I'm thinking about genetic testing. I'm thinking about costs of testing. I'm thinking about not ordering too many things, on this tissue to keep the cost low, but to get the right information. There's so many things that I'm doing as your physician, but a pathologist physician, that you just don't even know about. But maybe it's a good feeling that that, oh, somewhere in the laboratory, there's a physician who's also taking care of me and I don't even know about them. I mean, they're looking to us to really give them the diagnosis. But I do appreciate that it's a conversation. I think that this interaction that we have, and that's where multidisciplinary teams come in, right? A breast cancer is not just a breast cancer, right? The pathologist, the breast oncologist, the radiation oncologist, or the pharmacist, right? The advanced practice provider, like everybody has to get together and kind of come up with a plan, right? I'm thinking about the patient's age. I'm thinking about what they're presenting with, and interpreting what I'm seeing in that context, right? Because it's incredibly important. If it's a 94-year-old woman who's presenting with a particular symptom, it might be completely different from a 17-year-old, who's presenting with a similar symptom. So I think, to answer your question, it's there's lots of collaboration and lots of conversation between the physician who sees the patient and me. And I actually love that interaction because it only helps the patient for us to be more communicative. I really try and personalize this because more often than not, when I'm at a junction where I'm thinking about, okay, what should I do next in the diagnostic process? I almost always ask myself, if this was my mom, what would I do? Or if this was my own specimen, what would I do? And whatever the answer is what I do, right? I mean, it becomes pretty clear. And so for me, there is a fulfillment in being able to demystify it, give them the diagnosis, and then, to walk away, right? Because now I've done my job. I've passed the baton on to somebody else who has signed up for being the person who will tell the patient that they have a malignancy, who will guide them through the process, who will get all the glory of the remission.
That was beautiful.
Oh,
Dr.
thank you.
Kamran Mirza, thank you so much, not just for spending the time with us today to share what it is that you do and the importance of it, but for doing what you do. It's clear that you have a passion to really help other people. And we need that. We need that from the doctors we don't see who are on our teams. So thank you so much.
Yeah. It's my pleasure. I think that one last thing I will say is that there are many resources out there about interpreting your pathology report. I think that there's a nice resource out from Canada called mypathologyreport.ca. There are other resources through the American Society of Clinical Pathology, through the College of American Pathologists, through different support groups for patients, right? Hopefully your listeners, if they're patients or if their loved ones are patients, they can find the resources that they need. And I hope that through your amazing work that you're doing, we can help connect people to those resources.
Well, thank you so much. And for the full conversation with Dr. Mirza, head to thepatientstory.com, where you'll find human answers to your cancer questions.